And now it is time for the HC 2030 Symposium, Black Mommies and Babies, Reproductive Health, Rights, and Justice. Here's your facilitator, Marcia Henderson.
Well, welcome to our session this afternoon. The program description says Black women are more than 3 times as likely to die from pregnancy-related causes as white women. Even when receiving the same care, even when doing everything right, each year about 23,000 infants in the United States die before their first birthday. And Black babies are more than twice as likely to die as white babies. Equally grim is the increasing number of African American women who die due to pregnancy-related causes. The United States has the highest maternal mortality rate of all industrialized countries in the world, and the rate of Black women has climbed to a staggering 43.5 deaths per 100,000 live births, compared with 12.7 deaths for white women and 14.4 deaths for women of other races, according to the Centers for Disease Control and Prevention. The answer to the disparity in death rates has everything to do with the lived experience of being a Black woman and a Black baby in America. This session will explore health, rights, and justice in addressing this disparity across Africa and African American families and communities. To discuss this daunting issue and the related challenges, we have an amazing panel. In the interest of time, I will briefly introduce them in order for their presentations to go forward, but I encourage you to read their full biographies. First, we have Linda Goler Blount, President and CEO, the Black Women's Health Imperative, which is the only national organization focused on Black women's emotional, physical, and financial health in the United States. As an epidemiologist, she edited Index Us, the first research on Black women's health based on healthy Black women. Next, we will have Dazon Dixon Jallow, founder and president of Sister Love, Inc. She is a recognized visionary and advocate in the struggle for human rights, who established in 1989 the first women's HIV, sexual and reproductive justice organization in the Southern United States. Next, we will have Dr. Chewe Luo. She is currently Associate Director and Chief of the HIV/AIDS section of the Program Division of UNICEF headquarters. She has more than 20 years of experience as a pediatrician, tropical child health specialist, and research scientist. And to close our discussion, we will have Dr. Natalia Khanum. She is the United Nations Undersecretary General and Executive Director of the United Nations Population Fund, which is the United Nations Sexual and Reproductive Health Agency. She has more than 30 years of global and strategic leadership experience in the fields of preventive medicine, public and reproductive health, social justice, and philanthropy. Let's start the discussion with Dr. Blount.
Well, thank you, Marcia, and thank you to Healthy Churches 2030 for this opportunity to talk about an issue that, frankly, couldn't be more important and more pertinent than right now. You gave the very daunting statistics, as you said, about both Black maternal mortality and infant mortality. And we're offered many explanations for why these rates are. You know, epidemiologists and physicians would say, well, it's due to obesity and complications related to obesity. It's due to delayed childbearing patterns among Black women. Some would say it's due to lack of prenatal care, which some providers would interpret as lack of concern. But what we know is, while those things may be true, there's much more to that. and those things are certainly not the complete explanation. And so we have to ask ourselves why. What actually is going on? And you touched on it. We need to look at the lived experiences of Black women. We've got to ask ourselves the question, what does it mean to be a Black woman living in this society at this time? So a few years ago, the Black Women's Health Imperative conducted a study, and we asked Black women to define health, and it was entirely qualitative. So we asked for words and phrases for what health means to them. And it turns out about 80 to 85% of the words and phrases that Black women use to define health were psychosocial. Things like I'm calm, I'm at peace, I'm in control. About 10% of the words and phrases Black women use to define health were financial. I can take care of my family, I can keep a roof over my head. Only about 5% of the words and phrases that Black women use to define health had anything to do with physical health or disease state. So what that said to us is Black women were saying, if I can get my mind right and my spirit right and my money right, I can take care of everything else. It's not that maternal mortality or preventing diabetes or breast cancer are not important to Black women. Those things fit in the totality of our lives. And there are other things that we have to contend with every single day that creates a context for those things. And that context has to do with the systems and the society that we live in. So our findings were actually aligned with some research that's actually been around for more than 30 years. When you look at the data, Arlene Geronimus, almost 30 years ago, talked about weathering, that Black women are actually aging faster than white women, if you can imagine that. The authors of the Black Women's Health Study found a causal relationship between racial and gender discrimination and uterine fibroid tumors and uterine bleeding. Tanae Lewis, a researcher at Emory University, found a causal relationship between racism and gender discrimination and changes at the DNA level. Literally, our telomeres were frayed, this cell life was shorter. And Fleta Mass Jackson found a relationship between racial and gender discrimination and low birth weight babies and maternal mortality. So what we know is we live in a context, and that the stressors, the environmental stressors that we are subjected to every day take a toll on our health. Black women have on average 15% more of a stress hormone in their system called cortisol than white women. And what that does is it triggers our inflammatory response, raises our risk for diabetes, hypertension, cardiovascular disease. So we see this play out in birth, in prenatal care, in our pregnancies, and in our postpartum experiences. This is why we see the gestational diabetes rates so high among Black women. It causes metabolic changes. Turns out if you give Black women and white women the same high-fat diet, Black women will gain more weight and gain it faster. If you give us the same low-fat diet, we'll lose less weight and lose it more slowly. Our body's response to stress by having chronically elevated cortisol raises our risk for all of the key drivers of maternal and infant mortality, except one. And that is providers who won't listen to Black women when they're telling them something is wrong during pregnancy, during labor, and during the postpartum period. We lose as many as 200 Black people to pregnancy and postpartum related causes every year because providers simply don't value Black people enough to listen to them. So I just want to sort of leave you with this and maybe sort of start the discussion this way, that part of this has to do with the way Black women are treated by their providers. Part of this has to do with the fact that there's a lack of research and reporting on Black maternal mortality. There are things called maternal mortality review committees that don't happen in every state and in every hospital. So we actually don't have enough data to have a complete picture of what's going on, nor has it been important enough to mandate that we have these maternal review committees and have the data. And the way we in public health and medicine talk about data and statistics would lead you to believe that the reason Black women die 3 times the rate of white women is because they're Black. There is no biologic or genetic determinant or reason for these kinds of disparities. So to sum it all up, what I would say is race is not a risk factor. Racism is a risk factor. And that's why the Black Women's Health Imperative, we're working on anti-bias research. I'm a PI on a study that looks at what is happening with obstetric providers, and we're developing a curriculum to help them learn to listen to Black women and to understand what it takes to get more Black women included in research in a way that respects them and values them. I'm pretty sure that at the policy level, if providers were reimbursed for getting quality outcomes among Black women during birth, we'd see the maternal mortality rates and infant mortality rates plummet. So with that, thank you, and I'm looking forward to the conversation.
So we will now go to Deson Dixon Jallow. Uh-oh, we need you to unmute. Unmute, please.
There I thought I had done that just as Linda was finishing. You know what I call that though? I call that the selfie mic check. So thank you for that, Marcia. I am so grateful to be here. And this panel is, I already know that we're going to basically sound like the choir in harmony. It is because the issue of Black maternal mortality and morbidity is not a vast, insurmountable problem to wrap our head around. It's very straightforward. It's very basic. The solutions are not necessarily straightforward in the current context of how we solve problems in this country or in a lot of places where health systems are not people-centered, not women-centered, not justice-centered. So we know that there's some complexities to the response, but understanding this issue of Black maternal mortality, I could sit here and literally say ditto to what Linda has just said, and then we could get to the solutions, quite frankly, because all of what she has said is the same. The organization that I work with, Sister Love, we've been involved in sexual and reproductive health rights and justice work for about 31 years. And we've always done our work with the lens of HIV. And from the beginning of the epidemic, for example, being invisible, not being included, not even having our conditions recognized by the public health system as because of our bodies and our gender and our responsibilities, but also our biological experiences, weren't even getting AIDS diagnoses. And by the time we were included, right, the main and most critical issues were about the fact that there were so many women who were diagnosed with AIDS primarily at the time that they learned about their pregnancies, and either had real major challenges with their pregnancies as a result of not getting access to appropriate therapies and treatments, but also all of the other social determinants that Linda talked about were also critical elements to whether or not they would survive or that their babies would survive. And the virus at that point may or may not have had anything to do with it. And so when we come from an HIV lens into the reproductive justice space, there are some critical elements that we were not confused about, that we were grateful to be included with the Black Mamas Matter Alliance, because from an RJ perspective, this is an organization, a group of advocates, mamas, providers who understand all of the intersections that go on in women's lives, especially Black women's lives, and that the social justice contexts around maternal mortality are just as critical for us to have resolution and solutions around as are the reproductive health or the public health contexts of that. So there are a few things that we've been working on as partners with Black Mamas Matter that really brings to, I think, the fore, in addition to what the policymakers have raised up and still not moved far enough in terms of comprehensive approaches for us domestically, but what we have also not done is recognize at the community level how much more we can be powerful enough to support more issues around pregnancy and delivery and maternal health. And at the next level, there's a reason and a need to connect what our experiences are, especially those who are Black women and in the Deep South, with the concomitant experiences of women of African descent in the global South and around the world. And some of those issues are still associated with racism and with sexism and misogyny. And they're also associated with violence, including gender-based violence. We know that from a three-pronged perspective, that the maternal mortality, especially of women living with HIV, that the three pieces of having bifurcated healthcare, HIV over here, obstetric care and reproductive health care over here. If I have a mental health or substance use issue, it's over here. And then all of those other intersections that happen in my lives are even in more different places around housing, around economic opportunities or the safety nets. So it goes beyond the prenatal care, it goes directly into the overall environment. So if I talked about the definition and how we look at reproductive justice, just so that we're all clear about the same page of how all of these issues fit together. Reproductive justice, according to Sister Love, and sharing this definition within our own voice, National Black Women's Reproductive Justice Agenda, as well as Sister Song, Women of Color Reproductive Justice Collective. Reproductive justice exists when we have the human right to bodily autonomy, including the right to control our sexuality, our gender, our work, and our reproduction. That right can only be achieved when all women and girls have the complete economic, social, and political power and the resources to make healthy decisions about our bodies, our families, and our communities in all areas of our lives. And if you extend that to what we might consider as Black maternal or birth justice, then it extends to the opportunities around the choices that we have in terms of how we manage our pregnancies, where we give birth, and with whom we depend on and trust to process or have that delivery and that experience. And so, for example, in the history of how allopathic healthcare or the clinical care components have not only worked to create structures that work against our traditional, our cultural, our multi-generational ways of experiencing pregnancy and birth and delivery, is that we have excluded, not we, but from a governmental, political, societal level, we've excluded the respect and the level of credibility and honor that should be given to midwives, to lay midwives, to doulas, and to mamas who continue to support mamas. The peer context of protecting women during pregnancy, during labor, and post labor and postpartum are all a part of the components I think that will help in terms of how we address at the community level, preventing more maternal mortality and protecting our families and our communities. Another aspect of that, in terms of making sure that women have access to the services, is some of those obvious policy issues that we all know that we need. Not only having universal health care in this country, but universal health care in the world that has certain standards of care that recognize and take into context the lived experience of women of African descent, that we respect their stories, that we do listen to them, that we are making sure that at every table where policy decisions, where design of practices, clinical practices, birthing practices, where the design of any of the resolutions and the programs that we are creating are absolutely including the leadership of Black women, Black mothers even, making sure that the work that is to be done is holistic, that it is accountable, especially in research, and that it is intended and built around the concept of building power for women to thrive, and not just about dealing with the judgment, sometimes the shaming, and sometimes the blaming that comes when women are not behaving when women are not conducting or holding and managing their pregnancies in the way that others in places of power and authority may want or think that they should. So I'll close on two things as time runs out. And one is just sort of this, I think one of the powerful commentary that comes from Black Mamas Matter Alliance and the work that we've been doing. And we're very clear that to adequately address the issues, policy and program solutions must center Black women's voices, our experiences, and our leadership. It is in our stories where our power lies. That's what I call Indigenous expertise, which is data, even in our traditional and clinical science spaces. The Alliance also amplifies and supports Black women's leadership by identifying the different mechanisms that we already engage, that we have already learned over traditions and over heritage and over culture and through our spirituality, and that we have to be able to combine that with meaningful access to high quality and affordable, culturally relevant and comprehensive care. There was a question that says, what would we offer to the churches and what they can do? For me, a faith community has to create that community of caring space that everyone, men, women, and any identified in our diversities as men and women, have to be able to create a community of care and spaces for mothers to be mothers, and that we sit down in the context of our faith and our faith learnings and our practices, those things which only continue to judge and oppress and shame and blame, and that we engage and we use the ideas and the creativity and the faith of those Black mothers and those Black leaders themselves. I am so grateful for the time.
Thank you so much. We will now move to Dr. Chewe Luo. Unmute, please. Unmute.
Oh, thank you, Marsha. And
Yeah, perfect.
really excited to be part of this conversation. For me, I start by saying really the fact that women and children across the globe today continue to die from preventable deaths should be reason for all of us to pause and to continue to have these conversations about why the situation is the way it is, and to ask ourselves and everybody, what is it that we are not doing? I mean, I was amazed at the statistics that you started off with, Marsha, about the situation of Black women and children in the States, and even gave me more reason to pause. None of this is acceptable, and I think we should continue to carry the charge to make sure we change course. I look at my own situation today, and I just wanted to have a reflective moment of why I do what I do today with UNICEF, going back 30 years in my own country in Zambia, working as a pediatrician, and what I watched at the time, and similar conversation like we're having today, watching babies die of preventable child deaths just because of the many deprivations that the women and children that we are serving in our tertiary or center of excellence in Zambia were going through. And it gave me reason to pause at the time. And because, I mean, I can give you many examples. We had children coming in with diarrheal disease and pneumonia, a little bit too late for our medicines to work, and they were dying in our hands. And the desperations that I saw from the mothers, it's not my fault. I was trying to come. Maybe she didn't have that transport money to get to the hospital in time. The poverty that was in front of us, and the many children, I mean, about 25% of the children that I saw in my center came in with underlying malnutrition on top of everything else that they were coming into the care for. You know, simple balanced diets and poverty was the issue, and not so much what we're trying to do in the hospital to resuscitate and rehabilitate these children. They were going back to the same environments, and I saw the same mothers coming back several times with the same situation. We saw children with malaria. Malaria is treatable if you catch it on time. If you don't, these children are coming in with severe disease. One of them is anemia. And at the time I was doing my practice in Zambia, HIV was also hitting us hard. Blood was becoming a problem, and we didn't want to transfuse these kids because we didn't know that the blood was safe enough. So there were issues like that. And just going into now the HIV epidemic and the impact that it had on our children, and the fact that parents were bringing these kids into the hospital not knowing they had underlying HIV. And I had to tell them, the problem with your child is HIV. I said no to that. And I decided I'm not going to be part of this conversation. I need to be in a place where I can make a difference. And I want to say I struggled for many years to try to get to the point where I thought I could have some influence in changing the course for women. What is clear to me, looking back even at that time and looking at the conversation we're having today, is that hospital wars are not the solution. Health insurance can be available, but if we don't offer women the quality of care and the children the quality of care, and if we don't address the inequities in our environment, even that health insurance and that hospital war doesn't become adequate for these populations. Disparities in healthcare and support disproportionately affect the most marginalized people in our societies. And sadly, women and children of color are in that category. And so I think as I think about this, I want to actually mention that significant underinvestment in people-centered approaches, I think is key to our conversation. And as we think about some of the solutions, let's just reflect on what that could look like. In my own journey, I reached a point where I decided this is what I was going to do for life. And I can talk to some of the lessons learned that I have experienced and encountered in my path as I've worked in UNICEF now over 20 years. One of the things I want to say is that decentralization of quality care closer to where the populations that we're talking about are is one of the things we have to do. There are challenges as we think about quality and who's going to do that, because many times our best people don't want to work in some of these marginalized environments. And so decentralization also of tasks and making sure that we are working with communities, we are capacitating communities to be part of the solution. I mean, the doula system within maternal health is a good example of that. But I can tell you that in HIV, part of my experience has just been supporting mothers to mentor other mothers. So the Mentor Mother program that UNICEF has supported for a long time as a way of helping a woman navigate the healthcare system, which is sometimes complicated. And also when you're talking about HIV, there's a lot of stigma and discrimination. And that can be quite daunting for most women that are going through life changes just because they have an HIV diagnosis. I also want to say communities can contribute. And when you look at the faith community, there's a community for us there that can help us, not just in terms of providing peer support and supporting the networks in the community, but also in terms of the voice, making sure that they are looking and we are capacitating them with the numbers and the type of people we're talking about so that they can create that momentum and voice at the community level. And finally, I just wanted to talk about data. I mean, I think paucity of data in some of these populations is a problem. We know that what you count counts. And so very important, I know within our HIV work in UNICEF, we've encouraged local communities to actually develop their own dashboards to talk about the progress they're making or the lack of, and understanding who's being left behind and why, and really redesigning our programs to make sure that we're reaching out to those that are lagging behind. We can all help with this situation. I just want to say, again, hospital wars are not the solution. Thank you.
Thank you for that. And our next speaker, before we go to questions, and I'll suggest now that you all start thinking about the questions you want to put in the chat box. The next speaker is Dr. Natalia Khanum. Are you
Well,
there and are you on mute? Okay, wonderful.
thank you so much, Marcia, and warm greetings to my dear sisters of Healthy Churches 2030 and my brothers too. And a special hello to my beloved Pernessa Seal, who was a force of nature 25 years ago at the Beijing Women's Conference and has been a blessing in our lives ever since. I'm really happy to be here with you. Faith-based communities are absolutely essential for the continuity of the family, for the transmission of the values of human dignity, human rights, and love for one another. This is what the United Nations Charter also espouses. I am invoking Tony Cade Bambara. And what is religion, you might ask? It's a technology of living, end quote. We know as Black people that the church has always stood for the defense of those in danger of being left behind. And with everything that we've heard already and what's happening to Black mamas and babies in the world today, people of faith are needed to stand up for women and girls like never before. It's a question of reproductive health. It's a question of rights. It is a question of justice. And today I'm happy to be here to bring a global perspective from UNFPA, the United Nations Sexual and Reproductive Health Agency, to complement what my sister Chewalua has said from the UNICEF perspective. UNFPA promotes universal access to sexual and reproductive health and rights. Sex is a very difficult word for some of our communities to engage with, and yet as we hear, ignorance and fear can lead to death of Black women. We do help the World Health Organization in the 150 plus locations around the world where we work to set global maternal health standards. We provide guidance and manuals and everything you can think of, training to support more resilient health systems and communities. And we feature midwives and nurses who are very close to rural communities, to island communities in the places where we work, towards one of our biggest aims, which is zero. No woman should die while bringing life. And yet, in a short 24 hours by the end of today, 800 pregnant women will have met their death from totally preventable causes. So we have to be effective. We have to get out there and move to change that through the strength of our partnerships. I'm very sorry to tell you that the majority of the women who die from pregnancy and childbirth worldwide are Black women, many of them in Africa, but we've also heard about the disparities in USA. And I would hasten to add Brazil and the Caribbean and so many other places to that. So what can we do? Partnership is important. And as UNFPA, for example, like the whole of the United Nations, we are an international civil service. So we cooperate with governments. I want to know that Minister of Health. Actually, I want to know the Minister of Finance. I also want to get to know the women's groups on the ground. And again, others have spoken eloquently as to how alliances, civil society, student groups, university groups, and to me, very important, faith-based groups, even traditional chiefs who understand culture and know how to move people to action. That's who I want to be with when we're advocating for social justice, for equity, for rights and choices of women and girls, and especially their right to sexual and reproductive health. Now, Black women and Indigenous women, anywhere you go, are some of the most eloquent people you are going to meet. They are capable of raising their voices if we would only create that space for them to be heard and to make decisions for themselves. And the collective voice of women of African descent was heard loud and clear at the Nairobi Summit on ICPD 25 last year. Exciting. A coalition of change makers made over 1,200 commitments around the world for all of us to keep our promises and to accelerate access to sexual and reproductive health and rights for all women and girls, and to leave no one behind, which is the purpose of the Sustainable Development Goals for 2030. Now, despite these global commitments, why do women continue to lack access to services? Why are their rights continually violated? As I said, I just want to echo the points of view that the sisters have already put on the table regarding the multiple, the intersecting forms of discrimination and inclusion. It's a system that's embedded, but that was created by people who have the possibility of changing that. And what better time than now? So, sitting in UNFPA with my fantastic colleagues all around the world, we see firsthand these barriers. We see the barriers that women face when it comes to prenatal care, when they are in that labor room and not respected, and certainly in postnatal care situations, and even now with COVID, right? We were told COVID, the virus doesn't discriminate, whatever. Hello. If you're a Black woman, if you're an Indigenous woman, you are seeing now who is suffering the most the world over. And these disparities, Linda and others have already given you some of these statistics, they have impact. We're talking about people's lives. With COVID, violence against women. Imagine being trapped in an abusive situation during a lockdown, right? And femicide have skyrocketed. If you're pregnant in a rural community right now and you're in labor and you've got to walk down that road and there's a police roadblock because of COVID and you have to explain why you're out at midnight or whatever, what are you supposed to do? So it falls to all of us, and it certainly falls to faith communities as well, to support the heroic midwives. They're doing their best. As UNFPA, UNICEF, the World Food Program, whoever, we have to do logistics, even when there are barriers and, border closures and whatever, to make sure that these midwives don't have to use a raincoat or a plastic garbage bag as their PPE, so that they get the support that they need. And most of the health workforce, 70% globally, is female. And a lot of these so-called essential workers, I'm talking about the cleaner in a hospital. I'm talking about the person who supports us when we are ill. Very often she can be a woman of color. So ultimately, I think these persistent health and social and economic inequalities are fueled by that structural racism and institutional neglect. So stop it, end discrimination in healthcare systems. My last point, because there's so much that can be said, is quality data. We're invisible because no one comes to look. So if we open our eyes to ask who is being left behind, too often the experiences of Black women get subsumed under broader categories. So what I ask for is disaggregated data: age, location, gender, race, ethnicity, disability. And certainly, I think validating the lived experience of Black women, girls, and communities is really important. Now, in spite of these challenges, we're going to forge ahead. 2030 is there as a beacon, and engagement with faith-based organizations is more important than ever, because you can reach that heart, that mind, to bring peace into that home, into that community, to achieve that positive change. So this coalition here today is vital. And I know that I have to leave you with this fact. I've talked about 800 women who die in childbirth every day. Too often, my dear sisters, that woman is not a woman at all. She is a girl. She's 13 years old. She was married. She may be a victim of sexual coercion. How can she go home and say that she was molested when no one is going to listen to her and she's going to be shamed and blamed? Moreover, at this point in time, female genital mutilation must end by 2030. This is something that leads to complications of birth and pregnancy, and millions of girls are at risk of female genital mutilation. We can't afford to participate in a conspiracy of silence, as Billy Avery would say. We have to speak out. We have to defend each other. Our girls desperately need the support of the church, of the mosque, of the temple, ending child marriage, ending FGM, upholding her rights and choices. So to close, don't worry, Marcia, I'm wrapping up now, but Tony Cade Bambara also said, "The dream is real, my friends. The failure to realize it is the only unreality." So please don't stop telling our stories. Our voices need to be heard. We need to make sure that we are at the center of development. And when those sustainable development goals come through, that we also benefit. Thank you so much for the opportunity to speak with you.
Well, thank you all. There have been so many wonderful points made. And as we now are very clear about the issue or the range of issues, and as you've indicated, it's going to be on us, right? Racism is across the globe. The issues are similar. We've been going through this for decades. This is not a new problem. And the church often is our family. The church is in our communities. We have a wonderful opportunity right now to give some specific suggestions to our audience. What can they do when they go home to help with this situation? And so I'll call on Linda first and then go through to others. What can they do? What tips do you have for church members who know that this is the nature of their community?
This is, Marcia, as you know, my sisters have said, this is the beauty and the strength of the church. We, talk about having grown up in the church. That means something. That means people know you. They know your mama and them. And that's really important because oftentimes your doctors don't know you. A pregnant woman, a pregnant person, depending on what her resources are, she may see several doctors over the course of her pregnancy. So nobody really gets to know her. Nobody really understands what her pregnancy journey has been like. Sometimes the first time she sees a provider is when she's in labor, and that person has no idea what her experience is. So this is where the church provides such strength, because there are people in the church who know her, who can help guide her, who can connect her with resources, who can, most importantly, be with her. I think about the role of the church in training doulas and midwives, the health ministry, the maternal ministries that are in churches, who can train and provide job opportunities, obviously, so that no woman has to labor alone. No person has to go through the pregnancy and labor and delivery and postpartum journey alone. This is the role that churches can play to make sure that there is that foundation. One of the things that my mother used to tell me as a girl, and I grew up in the Presbyterian church, so we had a slightly different take on on things. But she used to say, you are valuable and worthy to God because you did one thing today, and that's you woke up. That's all you needed to do. And that is the message that the church can offer women in particular every single day, because we get a very different message about our existence and about our worth and our value.
Mm-hmm. I before I became the commissioner for women at the Food and Drug Administration, I used to work in the Bureau of Maternal and Child Health in the U.S. And I remember when HIV first appeared, and everyone was focused on gay white men. Very few were focused on African American women and babies. And so I made it my goal to put some of our grant money into that. And I was told point blank, quote, they're going to die anyway.
Oh,
Mhm.
And
yeah.
so with this, I was very clear about the mentality that we face every day. The difference was they said it to my face.
Mhm.
Okay. Very often that doesn't happen. My daughter happens to be a doula. And right here in DC, something that is the case is that Medicaid will pay doulas. There are organizations that train people like my daughter. After I spent all that money to Spelman College, she has gone and it's her passion to be a doula. And they will train you. And they will not only train you, you can be paid because Medicaid has the ability to do that. They identify high risk moms and babies, right? And so that's something the church can look into because churches have ways of putting together training networks
Mhm.
and resources. They can also look after the women that they know are pregnant, right?
That's right.
Because, as has been said, violence is one of the major reasons for maternal death, maternal and infant death in this country. Something else I would also offer is how do we help bring down that cortisol level that you talk about so much, right? You said that there is actually a biological action that is occurring that is causing us to age and to have things like preeclampsia and gestational diabetes, right? So the church is where we go
That's right.
to find grace, right? That's where we go to find our way of getting through our stress and struggle. So, have you seen some examples of what churches have done to help specifically? I'm really intrigued by this mentoring mothers program. I
Right.
really am excited about that. So, tell us more about what you've actually seen here in the US and worldwide.
I can share a little bit of what I've seen, and then obviously let others jump in. But what I've seen churches do is the health ministries will actually organize um, meditation groups, and it doesn't mean that you're necessarily practicing transcendental meditation. There are groups of women who get together simply to breathe. Some of them may not say anything, but what it is there's a group, there's a support, even if it's unspoken, a place to go for refuge where you can breathe, you can talk or not talk, but importantly, you can be without judgment and without fear. And what we know is that breath, there's a simple technique, 5-7-9 breathing. Breathe in for 5 beats, hold for 7, breathe out for 9. If you do that 3 to 5 times, it only takes a minute. You literally can reduce the amount of cortisol in your bloodstream. And so churches are organizing these groups simply so women can come together and breathe.
Mhm.
Yeah, it's the stress of it. I'm so glad also, Marcia, that when we're talking specifically about those intersections around HIV, that there are some pieces that we also want to lift up in, because there are those issues around cortisol, but and there are issues around inflammation, and there are issues around what the antiretrovirals mean, especially for preconception, for pregnancy, and for delivery. And some of the critical issues that we know that we have identified for women living with HIV, even before pregnancy, is that one of the most dangerous threats is isolation, right? It is that that's one of the outcomes of stigma, of internalized stigma, of shame, of secrecy, of being the only one or feeling as if I'm the only one. And so there's this real tendency to isolate even in the context of pregnancy, that there's also even more shame that's put upon a woman living with HIV who then becomes pregnant, because there are another set and layers of responsibility that folks want to lay on. And if she's younger, if she's out of wedlock, if or in is in what Natalia, Dr. Kanem has also expressed around prepubescent and adolescent girls who are literally in a sanctioned kind of sexual slavery, that still that isolation also means that we may not get to viral suppression, or we may not be able to sustain viral suppression. And that means that there are lots of women who end up with stage 3 HIV, and at the same time as delivering. And so there also increases maternal mortality. But in the faith space, I think we should look at it too in 21st century 2020, which thank goodness is almost over. I need one of those 579s when I think about this year. Is that we have so many faith institutions now that are completely virtual, that they have Sunday service online, that you can get your faith counseling online, choir practice is online. And so, in the same way that we would think about coming together in those spaces when we are able to, we have to create those virtual spaces for those same women in the same way that we would if we were in person. And I see that happening around other health issues. I think this can certainly be a critical piece, because we already have a culture, and I grew up in the Episcopal faith, so it's even a little bit more removed even when you were talking about Presbyterian, Linda. But in the context of, we have that tradition of the sick and shut-ins. Well, we may not all be sick, but right now we're all shut in. And so when there are specific conditions that elevate our risks for not surviving those conditions outside of COVID, then we should be using our virtual spaces to sustain the support that our women will need. And the last,
I think you're bringing up a very good point, particularly
yeah,
in this era of COVID, where
mhm,
isolation for all of us is mandatory. And we're about to come into a time frame where it appears that it is going to be even worse. And we know that this is a huge issue for our communities. And we're now thinking about how we can move into what people are calling our new normal. And so, with that said, the new normal is going to look differently. It will be challenging, but how can we think of opportunities? Because one of the issues with COVID is that women who are pregnant are having a disproportionately negative outcome.
mhm.
Pregnancy is now one of the major concerns as it relates to death or disability. And so that is again going to be burdensome in the Black community here and worldwide. So, Dr. Chewe, what would you say would be something that we need to look to as we think about COVID and our pregnant women?
Yeah, and thank you. I just wanted to go back to the issue of mentor mothers and how important, especially in the context of COVID, that is. I think connecting women to support each other. And I mean, churches and faith communities are so well connected, and they have the structures that actually can help in this world that we're in with COVID. But I just want to also to reinforce the issue of the digital space and the fact that we have more technology today really to connect people. The fact that we can be talking now from different locations and have this type of conversation, I think also tells us that it is possible to connect people, even though they're not going to be in the same physical space. So I just wanted to say that. And also to say, I think more importantly, especially today with COVID and the isolation that we are all faced up with, sharing experiences, from the women themselves that have gone through these processes, I think is going to be also critical moving forward. Um, I do want to also talk about the fact that even before we get to connecting women, making sure they're supportive of each other, sharing experiences, I also want to say that we can use the platform of our faith communities for sharing information overall. I mean, the sort of conversation we've had today, listening to the statistics, I wonder how many of the communities actually understand this. And so what is it that we can do to make sure that we bring faith communities to the space to be able to share this information in their platforms in a way that makes sense for their population?
We
That's
have a
what.
question that leads directly to what you're saying from the audience. And they are saying that two things. One, only 3 states, Minnesota, New York, and Oregon, and of course, I've told you, DC, Maryland area, reimburse for this. But the additional question, that was from Rhonda, Marcia has also asked, and I think they're linked together, how can organizations, the church and other Black women's organizations, put this on the global agenda so that we can get more resources and make this a bigger issue that we can all gravitate around?
Yeah, I think this is important, and I see Natalia smiling, but from where I sit in HIV, unfortunately, we have seen a decline in resources going directly to civil society, faith communities, and this is not for lack of attention to the issue, but this is, I think, about there's so many competing priorities that we are all faced up with today, including COVID. But before COVID, we had the whole migration issue in Europe and other issues coming up that is actually limiting the amount of money that is coming to us that we can use to actually work with constituencies like the faith community to make a difference. Having said that, when we look at our data today, and I'll use the example of HIV, and we did actually declare to the world that we'll end HIV or we'll end AIDS by 2030, and we're all rallying behind that. We've just been looking at our data for prevention, for example, and although we had set a global target of reduction of up to 75% by 2020, we're nowhere near that. We're at 35% reduction. And some of the reasons is exactly that, that we're not mobilizing and utilizing the people that are out there and the tools that we have to really have an impact. There's a recognition of that. And I do think that what we need to do is to develop these networks. The fact that we're talking together and we're having a conversation and trying to define what we need to do differently. I think what is important is to continue these conversations, to start to put things on the table and to start to actually look at the value addition of these types of networks to make sure that the people that have the purse string can understand that together we can achieve more and we have the solutions and the tools for us to get there. I don't know whether Dr. Natalia has anything more to add to what I've just said.
We have about 1 more minute left, and I think it would be perfect to give her the last word.
Well, thank you so much, Marcia, and everyone, especially people participating, because what excites me about being with you is that the church has a tradition of service. The ministries that you represent touch globally all over the world. And it is my hope that you will set for yourselves an ambition not to let COVID derail the march forward to 2030. I'm so delighted that it's 2030 that's on all of our minds. I expect that sex will no longer be taboo. We cannot afford to have our adolescent girls dwelling in ignorance. So please engage respectfully, of course, and you know how to do this. With us is Linda Goler-Blount, who heads the Black Women's Health Imperative. I've been proud to be on their board. In Nairobi, and we'll share the link on your Healthy Church's website, we made commitments, and we had ministers and imams and bishops and on who can inspire you. But what I'm more interested in is what can you do in the backyard? The Secretary General has said peace in the home and end violence against women and girls. Every faith community has to make this a reality. Why should 1 out of 3 of us be affected by sexual and gender-based violence in our lifetime? Oh no, and we have strategic people who can talk about menstruation, who can bring supplies and the perspective of what it is that we need to do to embrace interfaith collaboration. Hate speech damages Black women. We may not be there to feel the brunt of it, but Breonna Taylor and so many other names that we have to call, names that we must say, tell us that we have to link arms across faiths and traditions and go to the heart of the matter, which is human dignity. It is respect and love for that precious 10-year-old girl who I want to traverse into her adolescence, into her womanhood, feeling the support of her community. And you're a big part of that. Thank you,
And the
Marcia.
church said, amen. Amen. Thank you all
Amen.
so much. And we greatly appreciate all of your voices. And we know that our audience is all ready to take action in their home communities. Thank you for coming. And we are now going to move on to our next program.